seconds. Good. When we do an assessment of the knee, we want to make sure that we have proper equipment before we begin. Make sure we have clean towels. Be sterile throughout the process because we'll be handling gel and running the ultrasound, and we don't want to disrupt the patient in any way. So when we do a knee exam, we'll use this probe. This is the smaller probe, or the straight head probe. You can see it has a flat head on top. We'll place the gel right on top of the probe, just like that. And the probe has a notch on one side and a flat side or a rounded side on the other side. There's usually a notch or a little BB or something sticking out that indicates the left side of the probe. If you'd like to switch it in the software, you can switch it to which side you want it to face. When we do the knee, we break the knee into several different compartments. I like to do it from the suprapatellar area, the infrapatellar area, the medial compartment, and then the lateral compartment. If we want to do the posterior compartment, we can do that when the patient lies prone for that exam. So for the purpose of this training, we'll do these 4 compartments and go from there. We start here, and we will always point the left side of the probe up the body or to the left, if we can, of the patient. When we start with the probe in a vertical fashion, and we want to use the kneecap, the patella, as our landmark. So we always want part of the probe to touch that patella. So we'll be able to identify that on the screen very easily. So we'll go from here, we place it in this position, we identify where the kneecap is, and we want to find the suprapatellar recess, which is going to be just below this probe from here. This particular scan is a very important point to do first, because this is going to be where we're going to deploy our biologics or our stem cells or exosomes primarily. This will get right into the entire joint capsule from this position, and I'll show you how that looks. Now when we do the scan, we want to use the probe, and we want to hold the probe and the patient at the same time. So I like to keep my hands on the kneecap and the probe at the same time. It stabilizes the probe. As we take a look at the screen in a moment, we'll show you what that looks like and what the kneecap looks like. Now once we've identified the landmarks here and the suprapatellar recess, we'll turn the probe in this fashion like this, horizontally, again with the left side of the probe on the left side of the patient, and we'll keep it at the same area, and we'll be able to see the edge of the kneecap and the suprapatellar recess. We want to find that again. When we look at that in a moment on the screen, you'll be able to go down maybe 1 or 2 centimeters or so to that suprapatellar recess, and as we come down through this tissue, we find it, and from this lateral to medial angle, this is where the injection will be deployed. And of course, this is a great space here under the patella and under the suprapatellar recess to deploy stem cells or exosomes, because that will penetrate the entire joint capsule. So that's one compartment. From this position, I always like to go in the same order, so that way I never miss a spot. It's very easy to miss a spot if we have a patient with medial knee complaints and we go right to the medial knee and just go ahead and look at the problem. But I don't like to do that. I like to do the whole area to make sure that we're not missing anything. Now as we move from the suprapatellar region, we always want to get that patella landmark in the image. So when we do the infrapatellar region, we do the same thing. We want to take this probe and find this patella, and right about here, we want to put the edge of the probe on it and identify the image in a moment of the infrapatellar region. Now this particular image is going to show all the tissue that is, any pathology that's in here is going to be extracapsular, which means outside of this joint space. So this is an area where we don't typically want to deploy any stem cells or exosomes, but this is a great place for a PRP or possibly some fenestration with dry needling if we have a lot of pathology of this patellar tendon or the tissue around it. Now as we come on down to the medial side of the knee and medial compartment, when we want to find the joint space, you use the patella and you find the entire midline of the patella here, and we want to do the bottom 1/4 or 25% of the bottom of the patella here, and we come right on down to the side of the leg here, not near the patella or this patella fat area. We want to come right down here into this area. So if you can see that on the video, I'll show you again a closer image of that. So you'll be able to find the bottom 1/4 of the patella, and just like that, in this area we'll find the medial recess or the medial joint space. This is the medial meniscus area. This is another good spot to get into the joint space with a biologic, typically a stem cell or an exosome. As we take the product through here, you can inject it directly into the medial meniscus or through the meniscus into the joint space. And it's accessed right through this region. So we've got the suprapatella, infrapatella, medial patella compartment. We do the same thing with the lateral compartment. Again here, the lower 25% of the kneecap. We come down into this side of the leg, the lateral leg, and we'll be able to see on the screen the lateral meniscus. And of course we can see the lateral collateral ligaments, and right about there you'll see the lateral meniscus, the condition of it, whether it's intact or not, and it's not a bad place to deploy a biologic. As we come a little lower, this is that fibular head and the joint capsule. There is a capsule here at the fibular head. It can be something that we can inject with stem cells, but not necessarily the most important spot to do that. So the last spot we want to check in the medial compartment as we come down from that medial joint space is that pes anserine area. So we take this from the medial meniscus area and we just slide down the tendons to this area where you're going to see fluid space. If you see any fluid in here, that's the pes anserine area. And often, again, this is extracapsular, but this is an area that we would often use PRP or maybe dry needling to help free up the scar tissue or the adhesions in the tendon. All right, thank you. Let's do suprapatella recess. That's what we're going to find first. Again, we're going to find this here. All right, very good. This is the patella. This is that suprapatellar recess in here. We want to go below it into this soft space here. And that's a great space to deploy biological. As we turn this horizontally, and you can see now that same space. Put it right in here. See the depth of this recess is labeled at 1.5, maybe 1 3/4 centimeters. And that's a good place to deploy the biological. As we take a look at the medial knee, there it is there. There's the joint space right here, and this is the medial meniscus right here. Another good spot to deploy biologic through the medial meniscus or into the medial meniscus area. Lateral joint space is here. Lateral meniscus is on this particular patient is damaged, and it shows a great space though to again use stem cell therapy or exosomes right here. As we come down the medial joint space, there's the joint space there, and we come down a little lower, we're going to find the pes anserine. We're going to look for any fluid on that muscle. There it is. And these are the medial collateral ligaments here. And there is some fluid there. That's where the tendons insert. Now again, this area is a great place to use PRP or dry needling, but this is an extracapsular area, as is the infrapatellar region. Both are good for PRP or fenestration with dry needling.